Is advanced management of recurrent and metastatic gynecologic cancers, ovarian, endometrial, cervical, and we'll touch about vulval cancer. So these four cancers mainly. We're not talking about breast and gynecological cancers yet. Germany is the only country where gynecologists manage breast cancer, but rest of the world is still having general surgeons and breast surgeons separately dealing with breast cancer. So we're not touching breast cancer yet. So we'll be talking about ovarian, cervical, endometrial, and a bit about vulval. So I'm Dr. Shagun Agarwal, and I work in Swansea, UK, as a fellow over here in the Department of Oncology. And so, yes, about these cancers. So, when such patients come to you, you have to ask yourself if you're treating a recurrence or are you treating resistance. So, recurrence is basically biological failure of initial control. You had the cancer under control, the patient was in remission, but then later on in follow up, they develop either a second primary or a recurrence. So, and whereas in resistance leads to recurrence basically, where we'll talk about this as well, where some of the cells which escape the treatment and later on become the dominant cell and recurrence, of course. So in such cases, management shifts from curative to a strategic, personalized, and iterative treatment form. You do not just give chemotherapy as a lollipop to every patient. You have to really personalize the treatment for each patient, and that is what precision oncology.
Recurrent gynecological cancer demands a new strategy. Accurate restaging with PET-CT is critical. Management begins with a tumor board decision. Selected patients benefit from secondary cytoreductive surgery. Platinum-based chemotherapy remains the backbone. PARP inhibitors improve survival in selected cases. Checkpoint inhibitors are redefining treatment pathways. Radiation plays a key role in local control and palliation. Palliative care integration improves patient outcomes. Master Advanced Oncology Management. Stay ahead.
Is. So the learning objectives would be understand the mechanisms of recurrence, apply second line and targeted strategies, identify oligometastatic opportunities. It is very important that you know what oligometastasis is. So we have a slide for that. Integrate novel therapies, the new ones that have come into picture, and manage any refractory diseases, but in an ethical manner. First, about pathophysiology of recurrence, how does it occur and how do cancers recur? In fact, so the core mechanisms are initially there are micrometastasis. So while the PET scan cannot identify the distant metastasis, but they are usually present. So as the dictum says, if the tumor is more than 1 centimeters, it is already systemic. Now, whether these micrometastases show anytime in future or not depends on how they respond to the treatment. Tumor heterogeneity. So a tumor could be formed of certain cells which are sensitive to the tumor, to the therapy, and certain cells that are resistant. So that's a heterogeneous tumor. And later on, just the resistant cells remain. Clonal selection under therapy, it is again the same thing. Clonal selection of the resistant tumors, like it happens in microbiology, we study for bacteria, same way it happens in oncology, where there is clonal selection of the resistant cells. Immune evasion, these cancer cells will escape the immune cells of our body, and it's not able to identify where the cancer cells are, and hence they are able to grow. And cancer stem cells, certain cancer cells themselves become stem cells and they keep multiplying. So primary resistance and acquired resistance. Primary resistance is
recurrence begins at the cellular level. Not all tumor cells are eliminated during treatment. Some cells enter a dormant state, remaining inactive for long periods. The surrounding microenvironment provides the support cancer cells need to survive. Cancer evades immune surveillance and detection by the body's defenses. Cells acquire resistant mutations through genetic evolution. Micrometastases can spread undetected through the blood or lymph system. Reactivation triggers angiogenesis, forming a new blood supply for the tumor. Dormant cells can reactivate and begin to proliferate rapidly. This complex biological process eventually leads to clinical recurrence.